Welcome to the first virtual medical education event that's sponsored by Enhanced Medical Nutrition. It's my pleasure to be your host for the evening. I'm Todd Davis. I'll give you a brief, my brief background here in a second, but first off, I want to thank everybody for making the time to join us. I know that you have other things you could be doing. For example, there's a presidential debate, or not, no, I'm sorry, no debate, but a presidential town halls going on simultaneous to this. So anyway, thank you for making the time to join us this evening. So for my background, I spent the last 33 years in orthopedics, working at Zimmer, at Biomet, and then at Zimmer Biomet in various functions, from sales management to marketing to then general management. I retired about a year and a half ago as president of the global knee business for Zimmer Biomet. And it was my fortune that shortly after my retirement, I met Eric Zimmerman, someone you'll all meet later this evening. Eric is a co-founder and CEO of Enhanced Medical Nutrition. And as soon as I saw what EMN has done and the product that they've created for the orthopedic patient, I immediately saw the benefit to the patient journey. And I really do believe that nutrition is one of the very underserved ways that we all in this industry can help our patients do better. So it's been my pleasure to advise Eric and EMN over the last year. And again, my pleasure to be able to host and moderate tonight's event. We have a very succinct and evidence-based presentation for you, really focused in three areas. So we're going to focus first on the basic science, the protein and carbohydrates, why and what. Then we'll get a chance to hear from one of our orthopedic surgeon clinicians who's actually incorporated the EMN Orthopaedic Bundle into his practice, and hear from him and see how that's impacted his practice and his patients. And then we'll wrap up the evening with Eric, and he'll come on and tell you about the various business models and the way that you all can be connected to EMN and how you can incorporate the orthopedic bundle within your practice. We'll then conclude with some Q&A. In your Zoom menu, you have a chat button. As you hear or think of questions that you want to ask any of our panel members, just go ahead and load them in the chat, and we'll make sure that they all get asked and answered at the end of the evening. So with that, and without further ado, well, and I guess I should mention one more thing. There are a number of locations joining us this evening. We have an event going on in Madison, Wisconsin, so welcome Badgers. We have an event going on in Columbus, Ohio, so go Buckeyes. South Bend, Indiana, Notre Dame, and of course Chicago, Illinois, which is where this is really originating. So thank you again for joining us. And without further ado, we'll get right into our program for this evening. And again, it's my pleasure to introduce Dr. Stuart Phillips. He's been a collaborator with EMN since its inception in 2016. He is currently the professor and Tier 1 Canada Research Chair of the Department of Kinesiology at McMaster University in Hamilton, Ontario. He obtained his bachelor and master degrees in biochemistry from McMaster, went on to get a doctorate degree in kinesiology at the University of Waterloo. He is certainly a recognized global leader in the fields of nutrition, kinesiology, and exercise physiology, with over 200 presentations that he's given to meetings across the globe, over 200 peer-reviewed journal articles, and nearly 100 peer-reviewed review papers to his credit. So this evening, Dr. Phillips will take us through the basic science. So Dr. Phillips, off to you.
Great, thank you very much, Todd. I just get my screen shared with you all here. So yeah, thanks very much, Todd, and thanks to Eric and the crew at Enhanced Medical Nutrition for the opportunity to share this presentation with you, which I've entitled Nutritional Support for Surgery, Preparing for the Fight and Then Recovering Afterwards. My small confessional is that I'm an exercise person by training, but I look at things from a biochemical perspective. but really my interest in supporting surgical patients has grown out of the fact that I view surgery much like an athletic event. In other words, that it's a tremendous stress on your body, and that it makes little sense to not prepare for that event, both from a nutritional standpoint and, if you like, and if you had the opportunity, from a training standpoint. So viewed from that standpoint, that's where I'm coming from this evening. These are the funding sources that support the work that we do, and some disclosures that I need to make. I'll just give you this sort of vernacular here around prehabilitation and rehabilitation, and give you my language and the way that I view things here. So from a prehabilitation standpoint, if there were a clinician or a therapist talking to a patient, it would be to prepare someone to withstand the rigors of traumatic event or surgery in this case. Whereas if I were a coach or talking to an athlete, I would say that prehabilitation is essentially a form of training. We're getting ready to perform. And then rehabilitation, it would really be the action of, in this case, restoring someone to health or normal life through training and therapy. Whereas the clinician or the therapist talking to the athlete would say, this is returning to play if they were injured. So it's really some cross-cultural definitions where we're talking about a stressful event in the case of surgery, or in the case of an athletic event being something that you obviously prepare for. And so that's the context in which I'm couching all of the paradigms that I'm going to discuss here. So when we talk about prehabilitation, this is the training or the preparation for the stressful event or the catabolic crisis and immobility, if you like, that is associated with the surgery, and then the rehab, which is the recovery. And this is a model that Franco Carli has sort of immortalized in terms of preparing a person for surgery, is really trying to elevate their functional status or the functional status of the tissue that's going to undergo the stress, so that we realize that there's going to be a decline in function and probably a decline in the quantity of the tissue as a result of that stressful event, in this case surgery, but the functional recovery is going to occur quicker and maybe even lead to somebody coming back stronger than they were prior to the surgery. Whereas if there's no prehabilitation, as you can see here, the individual would not have the opportunity to recover, would experience a sharper decline and a deeper valley, and take longer to recover, and possibly in the situation with surgery, be exposed to greater stresses in the recovery period that might result in readmission or revision. This is a great quote I like to borrow from Dave Evans. He says that surgery is much like a sport, and I couldn't agree more. And he said, you know, we have to be trainers. If we're not well trained and you're not ready for surgery, then you're not going to do well. So from that context, it's really a nutritional preparation that I'm going to talk about. So to prepare for the stressful event, what we need to do is, if we can, is to train. I mean, obviously, physical therapy prior to the event would set a person up for a more rapid recovery. At the same time, if I were to tell an athlete to get ready for a stressful event, it would be fully hydrated and to fuel appropriately. And the fuel that powers any athletic event, and much like trying to withstand stress, is carbohydrate. And so I know that some of the carbohydrate pre-feeds resemble, in terms of their composition, very similarly isotonic sports beverages, for example. And then we're talking about preparing the musculoskeletal unit to withstand stress. And that's where protein comes in. And that's what I'm going to talk to you, or spend the majority of my time discussing with you this evening. There may be some surgery-specific goals, of course, in maximizing or optimizing blood sugar regulation, as well as medication optimization, which probably don't concern the athlete too much. In the post-surgical suite, then, we're really talking about recovering, and it's a simple strategy for athletes, and it's the same for patients. It's the 3 R's. We need to focus on rehydration, we need to focus on refueling or restoring carbohydrate into the system, and where I'm going to focus on is the repair and restoration of the damage, and to allow the healing process, in this case, to return, and that's going to require protein. So from the standpoint then of protein, and the analogy that I'm going to use is one of a brick wall. So the musculoskeletal unit, which would include any connective tissue as well as the muscle itself, is really a wall made up of bricks, which in this case are amino acids. And interestingly enough, these types of walls in our body, the tissues are undergoing persistent and ongoing turnover, or if you like, there are bricks being added to the wall and bricks being taken out. And in doing so, then you have an optimally, or hopefully optimally functioning brick wall. The schematic representation looks then something like this, and it's the processes of bricks going into the wall, which we're going to talk about as muscle protein synthesis, and bricks coming out of the wall, which we're going to talk about in the framework of muscle protein breakdown. So that when somebody consumes protein, you get a big stimulation of protein synthesis, you get a suppression of protein breakdown, and we get an accretion of tissue that's transient in this situation until you find that somebody eats their next meal. And so we get an area of accretion followed by a small area of loss, and then we get another area of accretion, and then another area of accretion following. So this would be our breakfast, lunch, and dinner time meals. The situation's a little bit different than when somebody either loads their muscle due to activity, because all of these periods then are amplified in terms of their effect. And the result is true even in the fasted state, is that you're losing less amino acids. So in this situation, you can envision that the tissue itself would be healing faster or regaining some of its structure afterwards. And that's a function then of loading and as well of the amount of protein that these people are consuming. There are two things that oppose this process, this normal fluctuation in protein synthesis and breakdown. The first one is aging, and the second one is disuse. So when you think about the case of orthopedic surgery, and the ages of your patients are probably in their 60s and beyond, you can expect that coming into the surgery, they're not in a situation of full, robust stimulation of protein synthesis, but something that's more like this. So this patient would be much more difficult to have them recover without consuming sufficient quantities of protein throughout the day, and emphasizing high quality protein as well. And I'll explain what that means a little bit later. The point I want to make here is that an older patient coming in is probably already under the throes of sarcopenia. They're losing muscle mass as a result of their age already, and simply the catabolic event, that's the stress, represents a decline that older people find it difficult to recover from without appropriate countermeasures that in this case would include obviously rehabilitation, but the nutritional support of high quality protein, such as the products that are provided through enhanced medical nutrition. So this sets up a so-called vicious cycle where older people, as a result of bed rest and joint replacement or illness, go through periods of inactivity. They experience declines in muscle protein synthesis. They lose muscle, recovery is impaired, and you can see that this is a downward spiral. Of course, what we would enjoy is to have these patients consume more protein in the post-surgical period, prepare themselves for surgery prior, and then more optimally recover in the phase afterwards. So the question becomes one of, can you overcome this anabolic resistance of both aging and disuse? And the simple answer is you can. This is a figure showing a study in which patients were exposed to 28 days of bed rest, and one group received an amino acid supplement, and you can see they're the experimental group versus the control group, and this is the change in their leg lean mass. So this is their muscle mass within excuse me, their legs during a 28-day bed rest period. And in the control group, you see exactly what we would expect, this disuse-mediated loss of muscle mass, and yet supplementation with high-quality amino acids and protein is able to offset that. The interesting part, too, is that there is a functional benefit that's associated with this as well. So it's not simply a reduction in the loss of mass, but you can see here there's a greater preservation of strength. Now, everybody declines, and that's what you would expect in a situation of muscle disuse, but the group that is supplemented for 28 days experiences a smaller decline. This is their voluntary single repetition leg extension strength, and you can see it goes down a lot less. The interesting point here is that maybe it doesn't require all of the essential amino acids that are present in high quality proteins, but there's one amino acid in particular that's important, and that's this amino acid here, and that's leucine. Leucine, if you remember, is one of the 3 branch chain amino acids, and in this experiment, again, it's a short-term bed rest model in middle-aged adults, and you can see that there was one group supplemented with leucine here that experienced a smaller decline both in their whole body lean mass, but importantly in their leg lean mass. And the same sort of results in terms of muscular performance was achieved. In other words, the group that supplemented with leucine were able to generate more force than the group that was in the control condition. So short-term bed rest induced atrophy and loss of tissue and function can be offset with leucine-rich protein supplementation. The active amino acid then is leucine. This is a branch chain amino acid, one of the 3 that's, if you recall from your biochemistry, isoleucine and valine are the other 2. And this stimulates a canonical signaling pathway within the muscle, as well as other tissues, to stimulate protein synthesis. And we now have a very good idea of how this works. It's through a very complex molecular mechanism. But I'm going to show you some data that hopefully convinces you that this is the key and critical amino acid. So the protein type clearly matters, and the devil, as is often the case, is in the details. So quite simply, not all proteins are created equal. And this figure is to highlight that the leucine content of certain proteins, and I'm showing you whey protein isolate and whey protein concentrate here. These are the proteins that come from milk, as opposed to soy protein isolates. This is a concentrate from pea protein. This is a concentrate from rice protein, and this is a collagen protein. Now, all of these sources of protein would appear on the label of a product as protein per se, but you would have to look to the list of ingredients to find out that whey protein, and if you look at this figure right here, it shows you that you would have to consume twice as much of these proteins or 4 times as much of this protein to get to the amount of leucine that is present in the whey protein isolate. Now, what does that mean? Quite simply, you're getting a suboptimal dose. You can see here with soy and rice protein that is only able to be overcome or compensated for when you ingest almost twice the amount here. So you can see that you can make up for a dose of whey protein, which is really optimal at 25 grams here, by consuming more, but it requires almost twice as much of this. And these are protein isolates, remember, these are not foods. Quite simply, the result is that you get less of a stimulation of protein synthesis. And this is work that a former graduate student of mine, Nick Bird, now a professor at the University of Illinois, did in older men, showing that other proteins that are present in milk, and in this case, it's casein, or the curd fraction of milk, or what you might see on ingredient labels is caseinate. And so caseinate is the open bars here, and the whey protein then is in the black bars. And you can see quite simply that feeding these older individuals whey protein was far more effective at turning on protein synthesis. And even in a situation where we added exercise, the whey protein was much more effective. Quite simply, whey protein sits at the top of the heap with respect to the proteins that stimulate this anabolic process. So the take-home points I want you to walk away from here are that a catabolic crisis like surgery can be prepared for to improve outcomes. The declines in protein synthesis determine changes in muscle mass, and specifically the atrophy that we see in disuse situations. Aging and disuse induce anabolic resistance in skeletal muscle and possibly other tissues, so connective tissues such as ligaments or tendons, and maybe even in bone as well. But this can be overcome with the consumption of high quality protein supplementation. And by that, I mean proteins that are high in leucine, and you can offset some of this disuse-induced atrophy. Leucine is the key amino acid, and really what we're talking about in terms of recommendations are to train for surgery, to try and get ready for the fight. So supplementation pre-surgery is definitely recommended. Prehabilitative exercise would be optimal as well. We would like to introduce rehabilitation or movement as soon as possible. Even minimal amounts will work, and then people have even used neuromuscular electrical stimulation, range of motion exercises, and to try and time the protein feeding for post-contraction or post-rehab session, which is much akin to timing the consumption of protein following a bout of exercise, for example, to take advantage of the effect that exercise has. To feed high quality whey protein containing a high leucine content, and this would be done daily at regular intervals. Then the dose that we figured out to be optimal is around 25 grams per feed. I'd like to thank you very much for taking the time. I know it was a brief run through there, and I'm hoping that if you enjoyed the presentation and if you do have any questions, I'd be happy to try and answer them for you.
Great, Dr. Phillips, thank you very much. Appreciate that overview of the science. As a reminder, you have the green button, the chat button. Go ahead and put your questions in for Dr. Phillips, and we'll get to them at the end of the evening. So it's my pleasure now to introduce to you Dr. Ritesh Shah. He is a partner at Illinois Bone and Joint Institute, which happens to be one of the largest practices, orthopedic practices in the United States, and certainly the largest in Illinois and Chicago. He is currently the Chief of Orthopedic Surgery at Advocate Illinois Masonic Medical Center in Chicago. He did his medical school training at the University of Chicago, did his residency at Northwestern University, and did a fellowship at Washington University School of Medicine in St. Louis. He is certainly a recognized leader in outpatient total joint arthroplasty, an area that I had the pleasure of working with him in my previous life at Zimmer Biomet. He has over 50 research presentations and over 20 peer-reviewed journal publications to his credit. And so without further ado, Dr. Shah will relate his experience with the EMN Ortho Bundle in his clinical practice. Dr. Shah.
Thanks, Todd. Thank you. Stuart, that was an amazing conversation and a really great presentation. I want to thank EMN with Eric and Todd. Thank you for organizing this and thank you for the kind introduction. I'm going to share my screen here. Okay, so I'm going to talk a little bit more about sort of the clinical side of perioperative nutrition, especially as it relates specifically to orthopedic surgery. I think you heard a great talk on the basic science of EMN and specifically the leucine-based protein, but also the complex carbohydrate. And I'm going to kind of talk a little bit more about sort of the orthopedic part of this. So my practice, just as a background, my practice, I do outpatient total hip and total knee replacements, outpatient partial knee replacements, hip resurfacings, and a decent revision volume, along with MIS surgery. And then what doesn't relate, I think, to this talk as much is hip arthroscopic surgery as well. You know, one of the things that I talk about a lot, one of the things that we've really worked on a lot is the model of, you know, the patient-centric model for total joint replacement. So if you ask patients in the United States, or I think a large portion of the world, what are they looking for when they're asking for a total joint replacement? It boils down to basically 5 main things. They talk about the fact that they want to recover quickly, so kind of a rapid recovery process. They want to have less pain, or in some cases, no pain. They want early mobility. They want a durability and a long-lasting process to the total joints that they're about to get. And then they really worry about cost. In the United States in particular, it's become important nowadays as deductibles and copays kind of go up. So those are kind of the main premises behind which patients are thinking about when they think about total joint replacement. And then what don't they want, right? So they don't want pain. They don't want any real reduction in function. They want a recovery that's seamless, that's fast. They don't want to have you slowed down. They really don't want limitations. And then they don't want complications. And complications in particular, hospital systems, any groups like ours that are taking care of patients, and all the payers that are present in the U.S. Nobody really wants a complication. Most importantly, patients. They don't want to have any complications, big or small. So age plays an important role. And so when we think about patients that undergo same-day total joint replacement, even though there are some patients that may be older, and as you know, Medicare has allowed total knee replacements to be done in the ambulatory surgery center, and soon likely will allow total hips to be done in the ambulatory surgery center. We know that that patient population is inherently a little bit older, a little bit functionally slower, and potentially having more comorbidities. So we know that even in older patients, we can do same-day total joint replacements. This is a video of a patient who's 75 years old who underwent a total hip replacement. This is about 25 minutes after his surgery. You can see that he's walking with a walker. We're not talking about those glorious videos of patients sort of dancing or doing whatever they do without a cane. This is an average patient undergoing an average total hip replacement in a nice minimally invasive way, having undergone a nutrition plan and a same-day total joint. The oldest total hip replacement patient we've done in this process with same day is 84. The oldest total knee is 81. And these are patients that are kind of chosen and optimized, and that includes nutrition. In total joint replacement, a lot of the patient optimization has really been about antibiotic prophylaxis, DVT prophylaxis, making sure that we minimize narcotic utilization, appropriate pericapsular injections, making sure we rely on early mobility, and then kind of having that safety network built out with home physical therapy or outpatient physical therapy. And I think in orthopedics, we all agree that nutrition is important. We know there's certain labs that we look for, whether it's albumin or total lymphocyte count or white blood cell count. We say these are kind of the thresholds for when you should operate and maybe when you should not operate. But we haven't really figured out what we should do with those patients that potentially are malnourished. And is there a role for making sure that nutrition is a part of the optimization path for total joint replacement patients? It also applies to younger patients. So this is that glorious video, right? So that 50-something-year-old patient who undergoes a total hip, who 2 weeks after surgery is dancing and walking. This is a patient I met who had a couple of trekking poles and was walking around for many years with trekking poles and was worried about taking his daughter to his college visits or her college visits. And now you can see that, again, with an optimized plan and nutrition being a part of that optimized plan, patients can do really well early, whether they're young or they're old. So now specifically to orthopedic surgery and what happens with sarcopenia, some of what you heard about on the basic science side with Dr. Phillips earlier. So we know that sarcopenia is a progressive loss and a degenerative loss of skeletal muscle mass and function that's associated with age. And we know that sarcopenia has increased risk. So in a study that looked at risk factors for elderly individuals for falls, they found that sarcopenia was an independent risk factor for falls, disability, postoperative complications, and mortality. And so this applies to our elective patients in orthopedics, but also potentially applies to our patients who are the patients that are hip fracture patients, the geriatric population that might be admitted in the hospital. In orthopedics, we also had studies that looked at sarcopenia, finding that 44% of orthopedic patients are actually reported as being sarcopenic. And interestingly, in a spine surgery article looking at thoracolumbar spine surgery, they found that sarcopenia had a 3 times higher risk of complication in the postoperative morbidity and mortality process for spine patients. And then what about infection? So we know that surgical site infection prevention is a huge process right now. And we know that there's so many things we're doing with regards to chlorhexidine washes, with regards to appropriate and use of potentially saline or other washes intraoperatively, patient optimization when we think about diabetes and hemoglobin A1C management, and what we're doing with wound closures and other wound devices. But have we really talked about nutrition? And so we know that sarcopenia is a risk factor for periprosthetic infections following total knee and total hip replacements. And this is an article in Journal of Arthroplasty in 2019. So once again, sarcopenia we know is a slow and progressive loss of muscle mass and function that's associated with aging. We know that there's measurable declines after the 5th decade of life in muscle mass and function, and the loss is about 0.8% of muscle mass per year, and about 1 to 3% muscle strength per year. And this, as you heard in Dr. Phillips' wonderful graph demonstrating the fact that these are modifiable issues that can be changed with amino acid and protein use, along with mobility and exercise. So what happens when you have muscle atrophy and muscle weakness? So we know that in patients who have reduction in functional mobility, we know that they have impairment in balance, and they have increased risk of falls. We know that, again, cost, again, an important part of what patients are concerned about, but also what payers are concerned about, what hospitals are concerned about, is that we know costs are greater with increased healthcare utilization with patients who have muscle atrophy as well as weakness. So malnutrition in orthopedics has been studied and has been linked to several issues. We know that wound healing, wound complications, persistent wound drainage, wound infections. We know that there's an increased susceptibility to infections, both deep and superficial, and with that, there's increased morbidity and mortality. It's been reported that 1/3 of the patients that are hospitalized are malnourished. We know, again, from what we just learned earlier, that there's a 3 times increased risk of potential complications with malnutrition. We know that, again, preventing readmissions within that 30-day episode or that 90-day episode becomes really important. We know there's a 3 times increased risk of readmission within that first month. We know that periprosthetic fractures, so fall risk, is a 10 times increased risk of malnutrition. This is important for our older patients, especially if Medicare allows outpatient total hip and total knee replacements to be done, but also important for our geriatric population who might be admitted with hip fractures and other issues that are more inpatient-centric. We know that malnourished patients are at a higher risk of developing surgical site infections, odds ratio of 2.5, and a much more likely chance of developing a prosthetic deep joint infection, odds ratio of 3.6. So we know that malnutrition is one of the most, if not the most robust predictor for postoperative complications. And that's more important than even obesity. With all the guidelines around total joint replacement care, you know, with obesity and potentially not operating on patients who have a BMI of 40, or thinking about optimization when they're between a BMI of 35 and 40 before proceeding with surgery, malnourishment and malnutrition is something that I think in orthopedics we need to really examine and potentially have a game plan in terms of what we're going to do when we find malnourished patients, which again is 1/3 of the orthopedic population based off the data. So what about protein intake in surgery? You heard, again, a wonderful talk by Dr. Phillips about sort of the basic science of protein and leucine, an isovalent protein that's used. So protein intake, again, in the clinical sense, we know that optimal protein intake mitigates the loss of lean body mass, sarcopenia, and prevents or allows us to have anabolic resistance. It really depends. How much protein you should take depends on how old you are and potentially how sick you are. And so in general, it's 1.2 grams to 2.5 grams of protein per kilogram of body weight. And so if you sort of, I kind of look at this table here, if you go to the middle column here, which is about 1.45 grams per kilogram per day, the average patient, about 200 pounds, needs about 137 grams of protein per day. And we know when you looked at one of the other tables or graphs that Dr. Phillips presented, we know that there's a significant loss that occurs between prehabilitation, surgery, and post-rehabilitation. And so making sure that the patient has appropriate protein can go a long way towards prevention of complications, but even more important, making sure that they recover well and do well. So again, it's a modifiable, and protein intake is one of the most modifiable treatments for sarcopenia, frailty, and malnutrition. We know that essential amino acid supplementation, like leucine, has been shown to minimize leg muscle atrophy. And you saw that with whole body muscle mass, as well as lean lower leg muscle mass being affected in Dr. Phillips's graphs. Protein and amino acid quality is also critical in the promotion of wound healing. And so leucine-based whey proteins are obviously very important based on, again, the talk you heard earlier. And then protein is supportive for functional outcomes. This is what we're all after. When we do our total joint replacements, we're all after a more early, more rapid recovery with improved functional outcomes. And in turn, by doing that, not only do we provide a patient with a higher quality of care and a higher outcome, but also at a reduced cost. We know we're going to allow them to minimize healthcare utilization by having and supporting functional outcomes better. So you look at the ice solution here. It's 25 grams of whey protein isolate that you just heard in the talk previously, predominantly based on leucine. And then important things that, my wife is an immunologist and an allergist, and she sort of talks about this as well. It's grass-fed, pasture-raised dairy. You mix it with 8 fluid ounces of water or milk. And then I'll tell you from a patient standpoint, taste becomes important, and minimizing sort of some of the side effects becomes important. So they've been happy with sort of the two main types here, the vanilla bean or the decaf cold brew, for positive things about both. Compliance is important there. The rapid absorption is great for what we want, which is the ability for protein to do what it needs to do, to minimize wound issues, to maximize functional recovery, and minimize the risk of readmission and complications. But on the patient end, it also doesn't lead to an upset stomach. They don't have gastrointestinal distress. And then on the allergy and immunology front, we know that gluten-free and lactose-free products are taking off in the grocery stores regularly because patients are found to have gluten allergies or gluten sensitivity, or lactose allergies, lactose sensitivity more and more often. And again, this really affects compliance quite a bit. One of the questions that I was asked more often, I myself had this question, which is what happens with high proteins with regards to kidneys, with bone and liver issues. So with kidneys, we know that research demonstrates that high protein intake does not adversely influence kidney health or function in healthy adults. So if you look at GFR and you look at any of the kidney health markers, BUN, creatinine, these are unaffected by that. Again, the important premise here is that they're in healthy adults, right? So I will tell you that in a patient who's had a nephrectomy, I'm not going to be asking them to take high protein diet or potentially use the protein part of this process. In patients who have bone health, another question, we know that there's no, current evidence shows that there's no adverse effects of high protein on bone health. And on the liver issue, we know the high protein diets over 4 months had no effect on blood lipids or liver function. And so those two things I think are put to rest. There's been a lot of data regarding amino acid supplementation and protein diet regarding knee replacement surgery. You can see that in the top left corner, regarding other position papers on older patients, on what we can do with enhanced recovery with ERAS programs in multiple different subspecialties, as well as sarcopenia, which we mentioned earlier, and then the importance of whey protein to function and help with muscle mass and health. So that's kind of the protein end of this, and I'll share sort of my process at the end of this talk. I'll talk a little bit about carbohydrate loading for surgery. This is the other important part. So for a long time, in most countries currently, including the majority of the United States, 100% of patients undergoing elective surgery or non-elective surgery, as long as it's not urgent or emergent surgery, patients are asked to not eat or drink, so be NPO, for minimum 8 hours before surgery. And oftentimes we know that in the elective surgery world, as the day gets longer, those patients may be NPO and not eat or drink anything for sometimes 8 hours, 10 hours, 12 hours, 14 hours. And we know that that affects them from their recovery and surgical care. We know that there's a metabolic stress that surgery causes, and it can lead to issues resulting in hyperglycemia, so sort of this diabetes of injury. And we know that hyperglycemia, insulin resistance, is correlated with mortality, morbidity, complications, length of stay, inflammatory responses, as well as what we talked about earlier, wound healing and reduced muscle function. And we know that in patients who have prolonged fasting in our surgical population, they develop insulin resistance, hyperglycemia, they lose lean body mass, and then they have other things that we've always termed as anesthesia-related side effects, when in fact it could be the side effect of the fact that they've been NPO for a long time, which is postoperative nausea, vomiting, and discomfort, thirst, hunger, and anxiety. You know, when I started doing same-day total joints in 2013, I sort of asked myself this question: is how can we ask a patient to be NPO for several hours, and then within minutes after surgery get up and start walking and not experience the side effects like dizziness or nausea or vomiting? And so this really has helped minimize that. We know that by allowing for preoperative carb loading, the body is in a fed state. And so as opposed to being NPO, it is better for their insulin sensitivity. So here is a good graph, and I think this really says a lot to me, which is when you see the NPO, the blue bar here, you realize that there's a significant impact on insulin sensitivity from baseline. Whereas when it's a complex carb loading drink, you see how it right along the baseline, a patient kind of maintains that steady state. And so throughout their recovery, whether it's early rapid discharge or whether it's a couple nights stay, they can kind of maintain that baseline status. In ERAS protocols, we know that postoperative nausea, vomiting, pain, dizziness are all issues that can be a problem. And we know that with carbohydrate loading, it is an independent factor to reduce the length of stay. So we know that by doing this, we can reduce all of these side effects that technically we've always termed as anesthesia-related side effects, when in reality, it could be an aggregate of the lack of complex carb loading along with sort of anesthesia and the response with insulin sensitivity. Procedure-specific things, so I'll kind of focus on orthopedics here. We know that there's a reduction in insulin resistance with total hip replacement and hip fracture surgery in 2 studies that have looked at this when we think about complex carb loading. So the composition of the pre-recovery drink is 50 grams of maltodextrin, or complex carbohydrate. We know that it's evidence-based, and I won't belabor this too much because I personally don't look at this as much, but it's 12.5% concentration with an appropriate osmolality, and there's no sugar added. Most importantly, again, we all strive to standardize our processes for same-day and inpatient stay total joint replacements. And so we know that from a standardization process, it meets all the ERAS guidelines. We know it's a proven safety profile, and that it standardizes. This is where it really assists our anesthesia colleagues, assists our postoperative nursing group, is that it can really help standardize our hydration protocols and our preoperative and postoperative fluid protocols, which can be helpful for patients. We again know that minimizing insulin resistance improves length of stay and will improve and does improve patient-reported outcomes, which are all being measured. So from a guideline standpoint, we know the ASA, American Society of Anesthesiologists, has recommended 2 hours prior to surgery to drink a complex carbohydrate drink. And the Canadian anesthesiologists have recommended the same. When we look at the strong level of recommendations, the ERAS Society, the American Society of Enhanced Recovery, and the Enhanced Recovery Society of Canada have all recommended and strongly recommended the use of preoperative complex carbohydrate drinks at 50 grams. We know that from a perioperative hydration and fluid management piece, 50 grams of complex carbohydrate, maltodextrin, is recommended. We should, again, incite your patients to drink it quickly. It's not something you sip like a nice cocktail. It's more of a 20-minute quick drink, and you do it about 2 to 3 hours prior to anesthesia. I do 3 hours only because some of the timeline for surgery isn't necessarily as predicted. And if I'm running ahead of schedule, sometimes I don't want to delay the surgery by that. We know that simple sugars are different. Okay, so your Gatorade, which is asked very often, is what about a couple bottles of Gatorade? We know that those do not elicit an appropriate insulin response. So if you remember that graph with the baseline and sort of the insulin sensitivity, it does not elicit the same kind of baseline target that you would get with a complex carbohydrate maltodextrin drink. Gastric emptying studies. So one of the concerns anesthesiologists had early on is, do we worry that patients drink this drink and they're going to end up having issues with gastric emptying and potentially aspiration risk? And dynamic imaging of pre-recovery shows that it clears the stomach in 1 hour. So this can be really helpful for when you go and start using this in terms of educating your nurses. It's also very safe in type 2 diabetics. There are some contraindications, so patients who have delayed gastric emptying, obstruction, fluid restrictions, and type 1 diabetics. This is another good graph of sort of depicting a simple sugar drink, a Gatorade, for example, versus a complex carbohydrate drink. And you can really see, again, the effect that it has on serum insulin. Again, the importance of kind of targeting that baseline and not having a peak and valley that affects their post-op recovery. So here are some common suggestions. So loading dose, 2 pouches of pre-recovery the evening before surgery, and 1 pouch 2 hours before anesthesia if it's an AM surgery. For a PM surgery, again, 2 pouches of pre-recovery the morning of surgery, followed by 1 pouch 2 hours before anesthesia. And then directions for use, usually say that you want to stir or shake in 400 milliliters of cold water and drink all of it fast, under 20 minutes, preferably in 5 minutes. As a side note, patients have stated that the drink actually tastes very good, and they don't really mind that, which is good for compliance. Here's my process. I'm doing 14 days of protein preoperatively for all of my elective total joints. I'm doing a carb loading drink as suggested. As I said, the last drink is 3 hours before surgery. That allows me to make sure that if I'm ahead of schedule and I have to move somebody up, or if I happen to have a sudden cancellation and I have to call somebody in early, my day isn't affected by having to wait too much for that. And then post-operatively, 14 days of leucine-based protein. I like the standardization of glycemic control. We know that it's evidence-based protein intake. From an implementation standpoint, I like the idea that it's powder form, it's light. The box, when it's delivered, it's a light box that a caregiver or a patient can pick up from the front porch. It's not heavy. It would be as it would be for premixed bottles with liquid. Those can be quite heavy. We know a lot of our patients' caregivers are their older or potentially less functional spouses that might have rotator cuff issues or lumbar spine issues and can be painful to lift up heavy boxes. Patients have stated that it's easy to use, easy to coordinate, it's color coordinated, and a very simple kit. So heard a lot about that. Feedback-wise, from a cost standpoint, I can tell you that obviously there's always concern around cost. The cost is great for minimization of complications. The cost actually for patients, they haven't really been against it. Once they recognize the importance of this for their care, they really don't mind it at all. Similar to what they're doing in most of their life when it comes to nutrition, when you think about them paying for weight loss kits, when they're paying for other levels of protein that they kind of pick up from the grocery store or order from Amazon or other sites. With that, I'll kind of end. I think it's really important to look at nutrition. We've optimized a lot when we think about orthopedics and total joint replacement. We have cited that there are things we should look at in order to minimize problems when it comes to nutrition, but we have not come up with a game plan on what to do about that. And I think this serves a very good game plan. So thank you very much.
Excellent. Dr. Shah, thank you very much. A great overview of how you take care of your patients and how this has assisted in your patient care. Last but not least, I promised you Eric Zimmerman, who co-founded EMN in 2016 and is the CEO of that company. He's an experienced healthcare professional, having spent the majority of his career in med device and sports medicine, sales, and marketing. Eric has expertise specific to innovation in healthcare and surgical quality improvement initiatives, such as ERAS, which is Enhanced Recovery After Surgery. He graduated from the University of Winnipeg with a bachelor's degree in kinesiology and applied health. He's recently completed advanced coursework specific to quality improvement in healthcare and clinical nutrition. Eric will wrap up tonight's presentation with his insights into the EMN business models. Eric, it's all you.
Todd, thanks so much for the intro. I think best for last definitely doesn't hold true tonight. So thanks so much, Dr. Shah and Dr. Phillips, who's sharing these great presentations. I'd like to start kind of just briefly with the background and overview, just a bit more context about EMN, Enhanced Medical Nutrition. So we're a university-based company. We've been incorporated since 2016. As Todd mentioned, our focus has really been in enhanced recovery after surgery. Spending most of our time in really high risk, invasive procedure types. And, we've been fortunate to validate a lot of research around several products in these other service areas, really focusing on following the science. Even with the challenges of 2020, we still have 8 ongoing controlled trials this year, which is something that we're proud of. So today we're just going to kind of quickly go over what we've highlighted, which is the Orthopaedic Nutrition Bundle, the Ortho Nutrition Bundle. This is a special project we worked on quite hard to support, validated this model, developed it in Chicago, working with some partners and surgeons like Dr. Shah and others on the call. And really now we're at a point where we're working to share this information and offer this program to surgeons and practices across the country. So really to summarize what we've heard, from basic science, more detailed science, examples and experience of practice, especially in outpatient surgery. This is a program that's designed specifically to fit within that pathway. And something I'll talk about a little bit later, but I want to keep it short. It's really impressive at the end of the day how innovative and regimented and organized these outpatient programs are. Programs like Dr. Shah's, every step along the way, the patient education, the surgical technique, the anesthesia, the rehab. So these are all things that are, all kind of 5-star approaches, and really the niche that we found and that we're building on, kind of taking that experience from populations, let's say, who have a bit more high risk and people who need it the most, is plugging in that evidence-based program to support the patient who's undergoing total joint reconstruction. So really from a very simple perspective, the program's offered, it supports patients for an entire month. Patients follow it for 2 weeks preoperatively and 2 weeks postoperatively. Patients are taking 2 doses of iSolution, which is the protein isolate, per day for those 14 days pre and post-op. And that is not to replace food. Really, there's a mentality that comes from dietetics and gastroenterology that's kind of referred to as food first. Patients are still eating breakfast, lunch, and dinner. These supplements are really just used as an adjunct to help a patient get as close to or past that evidence-based protein intake that we saw presented both from Dr. Phillips and Dr. Shah, to help standardize that, and then really to avoid NPO. We know fasting is counterintuitive. You wouldn't starve yourself before coming to this meeting, before running a marathon, and that's something that we're really getting away from, especially in total joint replacement. If there's no need to be fasting patients prior to surgery. So I'll leave it there, but obviously we'll share contact information with any questions. This is just to review and highlight the products themselves. High level, I think what's important to kind of note here is that this is designed specifically for surgery, which we'll get into. But this is not something that could be taken off the shelf when you take into all the processing and really the science of how we make sure that leucine is available in a really high content. It's absorbed rapidly, by patients, and it's tolerated very well. So as far as what we've done from kind of providing a clear value proposition, we've engaged a lot of experts at a lot of various programs to provide this solution, obviously for patients as well, understanding that we have these these opportunities in front of us as far as nutrition as a modifiable factor that we can influence, without negatively impacting the clinic. And one of my favorite sayings along that line is clinical nutrition is really one of the most low cost, low risk high impact interventions available. And that's really what we're serving to do here, is to plug this evidence-based program into the practice and help support patients that way. Just to highlight, this is kind of more of a quick takeaway as far as some of the difference really between our product and commercial interventions. But it's something that we've also learned and taken a page out of our experience with oncology, which is it doesn't really matter how cool your science is. If patients aren't going to take the products, if they're not going to ingest it, it's completely worthless. So we really take that seriously and build that into all of these product offerings. And what you can see here in this picture is when you, the analogy I'll use maybe even with Todd, if he's had too much pizza or ice cream, that feeling you get of really being full and uncomfortable, those are slow digesting proteins that take a long time to digest and kind of give you that feeling of that unpleasant feeling that doesn't make you want to continue eating. So that's something that we've been able to completely avoid with this in terms of being rapidly digested and absorbed. And then just to Dr. Shah's point, kind of the practicality of this is a solution that's been built specifically for this total joint replacement patient, and it's something that is either showing up at their door through e-commerce, or something that they're taking away from the clinic themselves. And whether it's the patient or the caregiver, it's extremely intuitive and easy to follow. And these are just some other highlights that I think we can share following up with everyone who's registered today. So as far as implementation, these are some of the key questions, and I know there's actually quite a lot of questions that have rolled in here. So our Q&A will probably be short, and then I'll send some follow-ups individually. But this is part of what we learned through liaising with clinics like Dr. Shah's, as far as outlining what's the preferred model. Is this going to be designated through e-commerce or through DME? And by e-commerce is simply a referral. The patient is given the information of, here's an evidence-based nutrition program, and here's where you go to get it online at emnortho.com, and we're going to use Dr. Shah's code to procure it. Or perhaps if there's a DME or a shop that's affiliated with the surgery center, the patients can locate it there. And it's a very quick pitch, so we're not really adding workload to the clinic. It's very simple in terms of, this is something that patients can grasp quite easily. And with the practices themselves, we're looking at who are the team members in the clinic. So who can we engage, whether it's nurse practitioner, MA, PA, obviously the surgeon, as far as really the entire staff that makes up that patient journey. And what are those touch points as far as the booking, when maybe they're coming to a joint class, maybe they're being engaged in sharing some information online or through a patient engagement app. So those are all pieces that we're trying to fit seamlessly into and incorporate this program, all with the goal and the pursuit of supporting a new standard of care. This is something that I think we've echoed is quite a significant gap in the pathway currently, and something that we take away and really like to put an extra emphasis on is patient empowerment. If I'm a patient who's coming in for a Whipple or a total knee, I might not know what arthroplasty means or what a femur is, but I've been told by Dr. Shah to stop smoking, make sure I complete my exercises, and follow this nutrition program. So really, we're trying to engage patients to invest in their own outcome, and that's something that so far we've been very successful at, and we'll continue to follow that trend. So, Todd, I have a list of questions. I'm going to pick like 3 or 4 really good ones, because I know we're getting close to getting close to our deadline here, and
that's great. I'd gotten some questions just from text messages, and but between you and Dr. Shah, you answered them all. So yeah, you take it away.
So the first question I have is NPO status, how long? And so this is a stigma that really is something that we address head on as far as carbohydrate loading as an alternative to fasting. All of the guidelines support 2 to 3 hours for clear fluids. So even sometimes if we get a little bit of pushback from anesthesia, oh, it's been NPO since I got into the business, and this is something that we've been following. Typically, what we do is we provide the own guideline from the ASA, from the CAS, all the support systems, as well as our gastric emptying data that proves this is something that's safe and effective to take 2 to 3 hours prior to surgery. Happy to share some more information on that side. This is a quick question for Dr. Shah. I suppose we can throw this one at him. So any tips and tricks for onboarding as far as involving your staff, knowing that this is a shorthand. So it's basically just on top of everything that is going on in the clinic. What are some key tips that can help involve staff to share some of this information with patients? Oh, and I'm going to unmute you.
So first of all, I'll just say, I think everybody's learning in this space. It's a space that's still an unmatched. There's a need that we've identified, and now there's a game plan that we have in front of us and a pathway that we can use. I think we're all still learning in my clinic as well, just sort of how to propose this as part of many different things, right? So all of the things you've standardized and all the things you do for patients on a daily basis, there's a lot of things going on. The one thing that we tell patients is that, as Eric mentioned earlier, is there are a few modifiable risk factors that you can do relatively quickly. So the effect that nutrition has and the effect that it has in terms of 2 weeks before surgery with protein, and then those 3 doses of complex carbs and 2 weeks of protein post-op, within a month, you've done something really important that is a direct modifiable risk factor. And so that's something we tell patients. In terms of the staff, one of the important things, and we're having this conversation earlier today in my office, is the fact that, if you're patient-centric, you're basically saying that you have to do whatever you can to make sure the patient does well. And if you think nutrition is relatively easy, all the conversations we've had with any staff member in our group, which is about 150 surgeons now, or any orthopedic surgeons that I've ever talked about this, EMN 2, everybody says this is a no-brainer, right? In terms of nutrition for patients, we all know that it's good for them. And so that's where I would say the messaging comes from the patients to the patients from our staff, is that this is a really important and relatively easy modifiable risk factor agent that you have in front of you.
Yeah, no, that's fantastic. Thanks, Dr. Shah. Dr. Phillips, I feel like we got a lot of questions, and maybe it's just because all those graphs and the verbiage associated with them. So I'll start with an easy one. What about after post-op? And in this case, they're talking about more than 14 days. So this program is designed to be 14 days pre and 14 days post-op. I think the question is based on, does your intake change after those 14 days? Does it stay the same? Or would your per gram of kilo body weight per day, let's say, or your recommendation, progress, let's say month 1, month 2, and moving on to what we kind of call healthy aging?
Yeah, I mean, I think Dr. Shah addressed this. Most of your patients, given the age ranges at least that are sort of average for either total hip or total knee, would place them in an age range in which they're suffering from sarcopenia anyway, or some degree of loss of muscle mass. And a lot of the research that we've done over the last sort of 15 or 20 years has really indicated that older people need more protein than the minimal level, which is the RDA, and probably up to twice that amount. So when you talk about the quality of the protein that they would give, I would still recommend that they stick with something like this even beyond that 14-day period. I mean, the 14 days pre and the 14 days post, I look at that as it's just the pre-habilitation and getting ready, and the acute period, 14 days. Beyond that, and there's still a lot of recovery that has to happen. So, and I think that's commensurate with a lot of other bodies in this area in terms of recommendations for older people. So I would encourage people to go beyond that, but certainly for the surgery, the 14 pre and 14 post seems really appropriate.
No, thanks for that. And it's something that we get a lot of patients who call us and ask us, okay, my program's done. How do I keep going, right? Or what can I do now? So those tips and tricks are great for practitioners, but also, for the patients coming out of that kind of acute post-op period. Quick fire again for you, Dr. Phillips. Is 25 grams enough to stop atrophy? I think that's referring to kind of the trigger that you mentioned.
Yeah, again, knowing what I know about the product, it's the devil that's in the details, but the product's pretty special. It's not like all whey even is created equal. It's got a leucine content that is really, it's the gold standard as far as the industry is concerned. So 25 grams is a single dose, and the dose of leucine that your product has would be more than enough, I think, to prevent and mitigate the atrophy. In the Paddon-Jones and the English papers that I showed, those doses of leucine were on par with what you're getting with the 25 grams. And I think, to add to your point around this is not designed to replace food, this is in addition to, it really would be beneficial, for most people, only because breakfast is usually the lowest protein meal of the day. Maybe for them to consider adding it to meals and where they're getting less protein anyway. But 25 grams of your product it's a little different than other whey proteins. And so, yeah, it's a good dose of leucine.
Fantastic. Yeah, and that's something that we've been working on even with some of our patient engagement right now. Kind of adding to that is really just cueing patients that this is great to take in between meal times, or at those meals where you're ingesting a lot less protein than you might typically at a lunch or dinner. So breakfast is obviously a great setting for that. We do have a quick question about, this one always comes up, reimbursement. So this product is not directly reimbursed. Patients source through e-commerce or through the DME. It is often eligible for what's known as HSA and FSA components, and that's something that we've built in. And I would say a lot of these questions I have are leading into more deep science questions, so we might have to pause for the day. Otherwise, that will be the stroke of midnight here. So I think what we're going to do is I have everyone's contact information based on the registration. I think obviously we want to thank Dr. Shah, Dr. Phillips, Todd for your time tonight. This has been really helpful, and especially with the recording, we're going to be able to share this with a lot of our colleagues, up here and internationally. So, thanks again, everyone, for joining, and probably look forward to some follow-up as far as this long list, laundry list of questions. But appreciate everyone's time.
Yep. Good night. Thank you, everybody. Appreciate it.
Great. Yeah. Cheers for now. Thanks so much.
Take care, folks.
Take care. Thank you.
Hey, cheers.